All right, good afternoon, everyone.
Good afternoon.
Please excuse me, I'm used to in City Council, we have a gavel to get everyone's attention. Well, welcome everyone. My name is Rafael Salamanca. I am a council member for the South Bronx. I am also the chair for the Land Use Committee. And I want to thank everyone for joining us today for what I hope will be an insightful conversation on responding to the opioid crisis in the homelessness community. I would like to thank Supportive Housing Network of New York for hosting this panel today and introduce our esteemed panelists. First with us, we have Mr. Luis Fernandez, a credentialed alcoholism and substance abuse counselor at Care for the Homeless.
How you doing, guys?
How are you? We had Dr. Allison Grolnick, Chief Medical Officer at Project Renewal. We have Ms. Andrea Littleton, Medical Director at BronxWorks. And by the way, they had a gala last night. It was awesome. Congratulations. And finally, we have Mr. Raul Russi, Chief Executive Officer at Acacia Network. The rapid rise in opioid-related deaths has devastated communities around the United States, including the city of New York. For decades, the South Bronx community I represent has been battling issues surrounding rapid opioid use due to the number of methadone clinics, needle exchange programs, and drug dealers in the community. And this crisis has hit the homeless population hard as well. There's a lot of work to be done, and that's why I've teamed up with Acacia and the 3rd Avenue BID in the South Bronx to form the Bronx Opioid Collective Impact Project, which hosted the Bronx Borough's first opioid community summit. It's why I introduced legislation in the city council that would require all New York City Department of Education schools to carry naloxone and other opioid antagonists. The organizations represented here today are pivotal in the city's effort to tackle opioid use in the homeless community. First, we'll hear a brief presentation from each panelist on some of the work they're doing, and then we'll have a panel discussion and close with a few minutes of questions and answers from the audience. First up, we have one of my dear friends, Mr. Raul Russi, the Chief Executive Officer of Acacia Network, who oversees executive management of the day-to-day operation of the largest Puerto Rican founded and led organization in the nation. In 2001, he became the executive director of Basics and led Basics until 2009 when it affiliated with Promesa and established a network he now leads, Acacia Network. Acacia employs more than 2,500 individuals and serves over 120,000 people a year in the areas of primary care, behavioral health, substance abuse treatment, affordable housing, and transitional housing. So with that, we'll hand it over to Raul.
Okay, now if I can get this little thing to work,
I got
then
you.
we'll...
Give me 1 second here. There we go.
All right, so we'll do... Oh,
I'm sorry.
that's not it.
Please excuse me there. This is not in order. There we go.
There we go. There we
I
go.
got you, Raul. Wait.
There you go. Thank you very much. I really appreciate the opportunity to be here with you, Councilman. A real friend. I think the Bronx is in for a really bright future with the leadership of Councilman Salamanca. You've been a real find for this city, and the future of the city is in good hands with individuals like you. So thank you for your partnership. For me, this has been a long journey from Buffalo, New York, where I started out as a police officer in 1970 to here in the South Bronx today. And I always used to tell my partner was in the police department, I wanted to go and spend one day in the South Bronx because, if you have a tough cop, you want to be in a tough area. So I wanted to go to the Bronx and work. It didn't work out that way. As a police officer, here I am today beating one of the toughest challenges that the Bronx has ever had, and that this is the crisis, the opioid crisis we have here today. The South Bronx and the Puerto Rican community has been in this battle for a very long time. For many, many years, the rest of the country quietly talked about the problem is there in the South Bronx, not across that country. So we were alone fighting that battle. And there are some real heroes and champions that took on that battle. To this day, I find that without them, there would not be a substance treatment system in the city of New York or even throughout the country. Julio Martinez, who you see there on the picture, was one of these great pioneers. When he was an addicted, homeless individual, and he would go into the hospital, spend a day detox, and go back out and continue to do that. He also had polio, and he formed a small group of men at that time, Carlos Pagan, Ronnie Williams, and himself, and they began to find ways to treat themselves and began to create the treatment communities there today. During the early 70s, they really decided to take this challenge to another level, and they decided to go to Albany and bring with them about 1,000 of individuals and form the camp in Albany to really bring the problem right to the face of government. And they called it the City of the Forgotten. In there, they marched together, as you can see in the pictures, and they battle government to try to get government's attention to what was going on here in the city. And eventually they were successful, and eventually Julio ended up as the director of the Office of Substance Abuse, and eventually really was the force behind the creation of what is now Oasis. I mean, he fought the mayors, the governor. He even lost his job over the fight. I don't know if you know this story. Some of you do, some of you don't. But in the struggle, every time he went to the governor to try to get the governor excited about working with this population, he would not get their attention. So he threatened to resign. Every time he went there, he threatened to resign. So in the final stages, he was in the middle of building a site in Brooklyn, and the governor's secretary wanted Julio to stop supporting that particular center and actually withdraw the money. He said, I'd rather sell hot dogs in the corner than do that. And he gave him the resignation. This time they took the resignation. And you know what? About a month later, there he was, parked outside the building, outside the Capitol, with the hot dog stand, and he sold hot dogs for about a couple of years to prove his point. Didn't make a lot of money. Maybe later on he might have regretted a little bit that he did that, but you know what? That's a man with honor. And that man was the kind of a leader that we need today with this opiate epidemic. I'm humble and proud that I've been able to succeed him in the work that we do in South Bronx. He was his last job was the CEO of Basics, and he passed away there at the site. And he gave us, till the very end of his life, he gave everything to this field. He and Carlos Pagan, who's still working, and you'll see him around everywhere. I know my team, Yabersi, she follows you around. Yabersi is one of our, Perez is one of our VPs. Yabersi, say hi. Runs 32 programs, 32 substance abuse programs from Dunkirk, New York, to New York City. Dunkirk, Buffalo, Albany, and New York City. And Carlos still hangs around with her, making sure she's doing the right thing. So you got a good partner in him. The reality is that our system at Acacia grew out of the bones of what Julio created. And the programs that are the 78 programs that make up Acacia were all found, mostly all founded by individuals of that era who gave everything to create a delivery system across New York City. Those three systems include behavioral health and substance abuse, and primary care and housing. The organization goes, like I said, from Dunkirk all the way to New York City, and now we're in Florida, Tennessee, and Puerto Rico. The behavioral health and substance abuse numbers are incredible. We treated a total of 3,050 slots of treatment that we have across the system. We also have gotten capacity waivers for all our programs to expand those programs to cover more individuals. We have a number of methadone programs across the state. I just want to share a couple of things. Both in Dunkirk, Buffalo, and Albany, we went there on our own because, if you remember back, there was a big push early on because Buffalo had become a real problem hotspot for substance abuse. So we went up to Buffalo, and we got into a real struggle because people don't understand the treatment necessities, and they, instead of working with you, they fight you. But we stayed in, hung in, worked with the community, worked with the elected officials, and we opened the clinic. It's been open now for 5 years, and it's doing great. The community loves it. It's become an anchor for community and programs in that community. One of the things I tell people all the time is in our center in the Bronx, we have a daycare, 125 slots of daycare in one door, and right next door we have 700 mental clients. We don't separate our families, right? Our program, residential programs, take in women and their children. Why? Because we don't separate families. If you want to deal with this epidemic, you got to deal with where it is and not hide from it or pretend that the drug users are one group and that the community is another. We're mixing together, and we got to make sure that we continue to do that. We have open access to our clinics. We invite people to come in 24/7. We don't create barriers for our folks so that people come in. And like I said, we opened it across the state of New York, not because we were asked to do it, but because it was needed. That's why we opened it. So a couple of, I'm not good at this kind of stuff, as you can tell. We partner up with our colleagues, just like I do here with Councilman Salamanca. We find partners. We partner with some St. Barnabas, St. Anne's Harm Reduction, Joyce. Is Joyce in the room? No? This is one of the most unbelievable person I've ever met in my life, right? When nobody else was doing anything, she took in the back of the station wagon boxes of needles and started doing needle exchange out of the back of the station wagon. Today, we're partners. I'm on their board. I'm on her board. I've been on her board for the last 7 or 8 years because I believe harm reduction is one of the winners for the future. If you can't keep people alive, you can't save them. If you can't keep their families alive, you can't save them. So I'm so proud of what she does. So, and then on the other side, we have primary health care. We have Twiggy Rodriguez, our VP for primary care here today. Twiggy, say hi so people who know you are. These are fabulous folks, right? I'm so proud of all of them. We have 8 clinics. 5 of them are federal qualified health clinics, and we're going to 6 pretty soon. They're open to the entire network, especially the homeless. We have one particular clinic that's dedicated to the homeless population, and the rest are obviously open to everybody else. We have most recently partnered up with CETCO, a great organization that we took over a few years ago to create the EBO. The EBO allows organizations to go in, right, and pick up the information on an individual and tell them exactly what benefits they're entitled to, right? So you don't have to go searching all over. One tool, you put the individual's information on, and you grab the information. Now you know how you can help them because you have all the information in front of you. So if you're interested in that, I'm sure Twiggy or your birthday would be glad to share that information because we're using it also. We continue to make sure that our mental health system is completely also available to everybody. Yeah, I know I'm not doing this right, but I'll get you up sooner or later. It's not my expertise clicking these things. We have made sure that every person that we could possibly train is trained on NARCOM. So in each of the fields, all of them have been trained. All the staff and peer have been trained. NARCOM kits with each trained person in every facility. Ongoing residential outpatient education, including the Carlos Pagan Center, to make sure that we have all the information people need to save people's lives. And that's what we're all. We are obviously client education, as we said, with the EBO is super important to us, so we're making sure that that's also available so people can get in and get whatever information that they want. We continue to partner with AmeriCorps interns and then archive training and applying for a SAMHSA OD prevention grant to train the pharmacists provide in our community. We also begin to have our own pharmacy to make sure that we have all the tools necessary to take care of our clients. Our housing, Lorraine Coleman, everybody knows Lorraine Coleman, she's around for a while. She's one of my lucky hires, our VP for housing, has 312 staff, Narcan kits at every site to make sure that we have. So one of the things that when I look at what we're doing with these programs is that we have decided that our history tells us all there is to know we need to know. We've been in the forefront of this fight, and what we've done is we've engaged the fight wherever it is across the state. And we've got the capacity, we have the access, we've got the enhancements that we need to do the work. Narcan training in partnership with everybody who will partner with us, and of course, working with all the external sources that we need to make it work. Acacia Network got its roots from Julio Martinez and the people in the South Bronx who fought in the very beginning to get this community healthy, and it continues to do exactly that. We're ready to partner, and we're ready to work wherever we're needed. Thank you very much.
Thank you, Raul. Just want to point out, St. Anne's Harm Reduction, they are located in my council district, and they do great work in the district. And just for those who do not know, not too long ago, the mayor announced the safe injection sites, 4 sites throughout the city of New York. Come on, good, okay. And one of them was in my district. I know that they awarded this to the St. Anne's Harm Reduction. When the mayor called me, a safe injection site is not easy to convince it's not easy to convince your community, hey, this is the right thing to do. But in my heart, I knew it was the right thing to do, and I did not hesitate. I told the mayor, I will accept this in my district. My only concern was the appropriate siting for this location. And I knew that Longwood Avenue was not the right siting, but 149th Street and 3rd Avenue was the right siting. And we were able to get community support and the 3rd Avenue bid support to accept that in that community, because that's where it belonged. Just wanted to point that out. So I just wanted to give a big shout out to St. Anne's Harm Reduction. Next we have Dr. Andrea Littleton, Medical Director at BronxWorks and the Faculty Advisor for the Homeless Outreach Project at Einstein Hope, and also the Faculty Leader for the Homeless Track of the Family Medicine Residency Program. Dr. Littleton is a family medicine physician at HRH Care Beacon and at Care for the Homeless Clinic. The Living Room, which is a drop-in shelter in the Hunts Point section of the Bronx. A graduate of Cornell University, she received her doctor's degree from the Stony Brook School of Medicine and completed her family medicine internship and residency at Montefiore Residency in Social Medicine, Albert Einstein College of Medicine at Yeshiva University. Dr. Littleton is an assistant professor in family medicine of Einstein Medical School and teaches both residents and students in family medicine. Dr. Middleton.
Thank you. Thank you, Councilman, for having us and hosting this talk. It's a very important talk. As all of you must know, the opioid crisis has really been a big problem for decades, as Mr. Russi said, but over the last 5 or so years, the problem has been that it's been killing a lot of people who suffer from this disease, which has really raised our awareness of it and raised our concern with how we can help with the epidemic. So I'll talk to you a little bit about the work that I do, and then talk a little bit about what we can all do to try to help address the problem. Like City Councilman said, I'm a family medicine attending. I'm medical director at BronxWorks, which, as many of you probably know, is a large, wonderful community organization in the Bronx that serves many citizens of the Bronx, both children and seniors. But one of the big things that we also do is provide housing for homeless individuals. The shelter that I work at the Living Room, we serve people who are chronically street homeless, so people who are really coming in from the street, and we're really trying to kind of get them in to provide them housing. I've been doing this work for the last 15 years or so, and truly enjoy trying to engage with clients and get them into care. At the Living Room, we have a medical clinic that is ran through Care for the Homeless, so we partner with them, and we partner with Montefiore to provide the work that I do. I do street outreach, so I go out in a mobile van to the street to engage with clients to kind of get them into care as well. And over the last 10 years or so, I've seen many of our chronic homeless individuals have suffered from substance abuse problems as well as mental illness, and trying to address those things is really important to engaging with them. With the substance use problems, it has been a problem for many years, but recently the rise in fentanyl being put in heroin has really caused a lot of our homeless individuals to be dying from their disease. And over the last year, we've seen this really hit the living room quite strikingly. We've had overdoses every week where we have to try to revive people. So we've really tried to push forward and get help from the city in addressing the crisis. I'll go over, basically, we had a city council meeting a couple months ago talking about this. As most of you know, overdoses happen everywhere, but it hits our homeless individuals more strikingly. They're more vulnerable. A lot of people who may have had substance use problems before tend to relapse when they become homeless because of all of the stress and things they have to deal with. So our community has been hit the hardest by this epidemic, and we felt like we need help and support with dealing with the problem. Some of the main ways that we wanted help and have been getting help with the city is in training both our staff as well as our clients in Narcan on the naloxone. The city has been really wonderful in pushing and getting the Narcan out to all citizens of the city. They have a new campaign about I Saved a Life. I'm sure many of you have seen this on subways and elsewhere, just talking about the wonderful effects that Narcan can have in saving someone's life, and really trying to encourage people, everyone, to be trained in it. If you have anyone in your life who is connected, who might have substance use problems, really knowing how to use it and having it available to you is really key. And we at the BronxWorks have really taken that on as well, and have trained all of our staff as well as many of our clients. It works well to partner with many community leaders as well. My students from Einstein Medical School have been a big part of our training and have come to the living room to train a lot of our clients, so that not just the staff have Narcan in hand, but some of our clients also, all of the clients who are at risk have the Narcan, and that's definitely helped us with the epidemic, because when the first-hand people who see people who are overdosing are substance users themselves, and so having them trained and able to use the Narcan was also key. One of the other big things, like City Councilman talked about, was the safe injection sites that are coming. This is just kind of a listing of all the Narcan programs, and the city has been great in outreaching to many of the community agencies and getting the staff trained to be able to train and give out Narcan. So there's many resources for people to be trained for it. Safe injection sites are coming to New York City. DeBasso has approved four sites, one in the Bronx, like has been mentioned. Then there's one in New York, in Manhattan, as well as in Brooklyn and in Queens. There's some hurdles to get over before we get there, but I think that it will be very welcome to have them, because we've seen research has shown in other countries where they have safe injection sites, they've really reduced the rates of overdose to nothing. So these two things, Narcan and safe injection sites, are certainly just a Band-Aid, right? They're just going to keep the person alive so that we can get them into care, but they're critical, because without that, the person won't be alive to really engage in getting them into care. But getting them into care is one of the key components with trying to tackle the disease, and I think that having medically assisted treatment has been a game changer for opiate abuse. Many other substances are not as privileged to have a great treatment for them, but opiates do. So we're trying to get medically assisted treatment, we call it MAT, into more shelters and clinics, and have providers who are able to treat people where they're at, I think is a key component in dealing with the epidemic as well. New York City has many methadone clinics, especially in the Bronx, that are available. Sometimes methadone may not be the best option for certain people, though, based on many things, having to go to a clinic. some of the side effects from it. So being able to also offer buprenorphine is also a key component with dealing with the epidemic. But there's not enough prescribers who prescribe Suboxone or buprenorphine. So that's been one thing we are putting forward to trying to get more providers to be trained. You have to have a waiver to get the training and be able to prescribe it. So getting more providers to do that, but also dealing with some of the reasons why providers may not want to do that. The city is trying to have an initiative to train providers, specifically nurse practitioners, and being able to treat with buprenorphine. And they are going to be putting that out soon with places, different sites throughout the city that the nurse practitioners are going to be trained at. And these are going to be throughout all of the boroughs, and they're also going to provide syringe exchange in them as well. So that will hopefully increase our providers that are actually being able to prescribe. Some of the big reasons why providers don't, though, is related more to the stigma of substance use, and that's something that we want to try to address with providers as well as the lay public, because a lot of people have a lot of preconceived notions of people who use substances and their behaviors, and a lot of time that limits their access to care. So trying to end the stigma of why and who uses will help us with dealing with the disease. Being a buprenorphine provider myself, I've treated over probably 200 patients with buprenorphine, and I can say firsthand that people who have opiate use disorder run the gamut of everyone. They could be a 17-year-old who got hurt, playing baseball and then got addicted to Percocets, to a 70-year-old who was given it for low back pain, to someone who's been homeless for many years, who've used other substances and then turned to heroin. It runs the gamut of all socioeconomic status, and I think when we become more aware of that and allow it to be conceived as a disease, not as something that is a character trait or a failure to people, will people be open and feel comfortable getting access to care. Like I said, it affects prescribers willing to treat. There's been research and studies done on this, and physicians who have been trained in being able to prescribe buprenorphine don't always necessarily go ahead and prescribe buprenorphine. And a lot of those reasons are physicians' preconceived perceptions of who are substance users and dealing with people who are substance users, and concerns about their trustworthiness, and kind of opening a can of worms of problems that some physicians don't feel comfortable addressing. And so trying to address some of those concerns and having a team approach can be extremely helpful. We are quite fortunate at Care for the Homeless. We have a team approach. I have Lewis, who is a CASAC trained and peer support, who works with me, as well as a medical assistant who helps to see the patients that we see at the living room. We do groups so that patients can talk to other people who have similar condition and discuss some of the struggles and obstacles to following through with care, and some of the stressors that they're going through, and those things can be extremely helpful to them. So taking a look back at kind of addressing the problem, I think it's on many fronts, and working together with many community agencies and trying to treat people where they're at and give them the resources that they need to get better care. Mental health and mental illness is a big component of why people become homeless, and also why people use substances. So providing mental health care on site, co-located as well with medical care, is really important as well to treating the problem.
So my part in the team that we have at Care for the Homeless is that I am a CASAC for the last 8 years. I've been a counselor for almost 14 years. But however, before I was a counselor, I was basically a drug addict. You know, I've been in recovery for 15 years, and thank you. Thank you. And basically, I'm like a byproduct of the opiate situation that's going on now. That it's been going on for I don't know how many years, 15, 100 years. But now I always consider that the Suboxone, the buprenorphine, I'm always telling clients, this is a magic pill, if you know what I mean, because if they would have had this kind of medication 15, 20, 30 years ago, a lot of people would have been saved. A lot of people would have been stable, And what we do I work with Dr. Littleton at the Living Room. It's a drop-in center. And what we do there as a team, she prescribed the medication and talk to them about the physical medical needs and stuff like that. My part is that I do the counseling, and I realized that there's a lot of places now that are not providing counselors for the buprenorphine. They're just giving them the Suboxone and let them go on their way. And to me, the counseling is a very important part of it, because there's a lot of clients out there that they will come in with with the problems that they're having with the heroin or pain medications, and they want somebody to talk to, not just basically just get a prescription and see you next week or see you next month. They want somebody to talk to and somebody that they could trust. My part as a counselor, since I've been in recovery for 15 years, I try to get the clients to be comfortable with me, and some of the discussions that I have with the clients, it's about the withdrawal symptoms, whatever they're going through, because I give them a little bit of, I could say indirectly, I give them a little bit of my history, okay? And I let them know that, listen, I know how it feels to have, a stomach cramp and, going through sweats and colds and sweats. So I understand what the situation is. Just relax. We're going to take care of you. And believe me, when you come in here, you're going to have a friend that you could talk to, someone that you feel comfortable talking to. And basically, right now, we are a very small program, but we have like 45 clients that are retained. They're on Suboxone, and we're providing counseling to them. And in 2 weeks, we're opening up another location. So, and both of them are in the Bronx. So the battle is still going. And I know that we are, with all the assistance that everybody in this room can provide, we're going to be okay, and we're going to be providing services for our clients for a very long time. Thank you.
Thank you, Louis. Lastly, we're joined by Dr. Allison Grolnick, who joined Project Renewal in 2008 as the staff psychiatrist and served as medical director for psychiatric services from 2012 to 2017, to taking a position as a chief medical officer in June of 2017. Dr. Grolnick earned her medical degree at the University of Medicine and Dentistry of New Jersey, R.W. Johnson Medical School, and then completed a psychiatric residency training program at the Mount Sinai School of Medicine. After residency, she went on to complete a public psychiatric fellowship at the New York State Psychiatric Institute of Columbia University Medical Center. Dr. Grolnick has also held positions at St. Luke's Roosevelt College of Physicians and Surgery, Columbia University, and the Metropolitan Center for Mental Health. Dr. Grolnick.
Thank you. Thank you very much. So I will sort of give a little overview of some of the things that we've done at Project Renewal, and grappled with very similar issues that have been mentioned previously. As most of you know, Project Renewal operates 7 shelters, multiple transitional and supportive housing programs. We have an 822 outpatient substance program. We have ambulatory detox programs, and 3 shelter-based federally qualified health clinics, as well as 2 mobile units that go throughout the city. We partner with multiple agencies in this room to provide on-site health care. What we've really thought about, obviously, have been sort of engaging with folks over decades with opioid use disorders and co-occurring mental illness. And what we've thought hard about over the past year is sort of integrating our programs and integrating our care so that we can address all the issues, the social determinants of health that I'm sure many of you have read a lot about, to address all the issues at one time. So we became an opioid overdose prevention program officially to partner with the city in 2017, as was previously mentioned. And we had been providing Narcan naloxone training for years, sort of throughout our programs, but really took a look and did it and partnered with the city to do it in a more systematic way. So as we developed the program with a program director and a medical director of those programs, each site receives an on-site champion, and that on-site champion is responsible for the ongoing training of their staff. But initially, we prioritized programs, so we had a large supportive permanent housing program with a clustering of overdoses at that particular time, prioritized them, as well as our shelters where we were seeing lots of overdoses, and as was previously mentioned, the numbers continue to rise. So we have multiple overdoses, a week, a day, in lots of our shelters, also in our housing programs. And so we, systematically went to every single one of our programs, identified on-site champions, trained our staff, and then, have subsequently engaged with clients to train them as well. As we know, they're more likely to overdose in a setting where there's not necessarily staff there, but a partner and a friend that they can give the Narcan kit to. So we rolled it out in all of our shelters, housing programs, and all of our health care, physical and behavioral health. We have psychiatric services integrated in all of our shelters as well as housing programs. And in our FQHCs, we have on-site in many of our locations, primary care, psychiatry providers, and in the outpatient substance programs, we have CASACs and other peers sort of integrated throughout these programs. We're hoping to incorporate the training at staff orientation so that there was a 3-day gap perhaps where someone would come on site as a staff member, and before the on-site champion would have a chance to train them, they might perhaps be working overnight shift and there was an overdose, and we were hearing feedback that they really felt unprepared at that moment. We have Narcan kits located throughout different areas so that operations center can grab a kit. We have it in our nursing programs, certainly in our healthcare programs as well. And then in some of the programs where there's identified to be a high amount of overdoses, we have talked about providing kits for each individual staff member so that they can respond immediately. So you can see here some data. We've been training for a long time, but started to track it in 2017, and the numbers have gone up in terms of number of reversals that we've been able to succeed. As you can see, most recently, in a quarter, that's 27 FH fiscal year 18 quarter 3, 27 reversals at just during that quarter. And remember, this is just ones that our staff are doing. Obviously, reversals that EMS are doing don't count towards these numbers. So you can see it just keeps going up. In terms of the naloxone training, we continue to train lots of both staff and clients, but you can see the shift in the light blue is the clients, and we've really focused, once we sort of rolled out to staff and there was an on-site champion identified, the focus now is training as many clients as we can. So we'll have fairs that will have peers come and try to engage with clients at these fairs to to train them before they need to give it. They can see how easy it is to use now. They've really improved the kits. It used to be a little more complicated. There were many steps to the process, and now, for those of you that haven't seen it, it looks like a nasal spray, and I think the big what we've had to work both with staff and with clients. I think the challenges are different. With staff, it's sort of understanding that you're not going to hurt someone by giving it, that there is a reason that they're referred to the emergency room afterwards so that we can continue to monitor them, but that you're not going to do anything to someone. There's very limited harm. With regard to the clients, the feedback that we hear sometimes is just feeling like there's going to be some punitive result to it. So it's about educating that we want everyone to have access to kits and to use it, and it's about engaging and helping people get into treatment, and trying to demystify and limit the punitive nature in a more harm reduction model. So what have been the challenges? It's one thing to give training to staff and to help them feel empowered to help when there's a situation, if it's sporadic. In some of our programs, it's becoming quite regular and routine, unfortunately. And so, these are residential aides, program aides that have, very little training and background. Actually, some of our best RAs and PAs are those that had been former clients, and so can engage and feel that they can really save a life, and they're saving lives, and they're crawling under stalls of bathrooms to administer Narcan. And it's not necessarily what they signed up for from the beginning. And so really addressing the burden and sort of helping staff process when they see such a traumatic thing over and over and over again. I think that we continue to engage and want to utilize more and more peers to engage with groups with clients after an overdose. So, not only are they you're providing Narcan and perhaps saving their life, but then what's next, and engaging them into treatment. So, we have multiple reporting requirements. Our partners are great, but there's lots of different partners, and so we have, multiple reporting that we do. And like I said, our goal is really to expand. The crisis, unfortunately, hasn't ended, and so we need to address, the immediate Band-Aid that was, addressed, but also continue to engage people into treatment. Peers are the best folks to engage. They've been through it. They can identify with our clients in a way that other professionals might not always be able to. So we'd love to have peers that were dedicated specifically to each client after they overdose, to have a caseload perhaps to continue to engage with them into treatment. But, we need funding to do that, and so that's been some of the challenge, as I'm sure many of you know. One other thing that we've done over this year is, access into care, and as was formerly mentioned, engaging with clients to provide whatever kind of treatment that they're interested in at that moment. And so how can we best, as an agency, coordinate all of our services to provide MAT and buprenorphine specifically to folks in different settings? So, engaging clients as they're tapering off of their detox, if they're choosing to continue on to maintenance, to be able to have them at a maintenance bup dose and then engage with them at that time, and then offer them choices. So if they're interested in talking, we would love people to want to talk more. Often they're not so interested at that time to talk. And so if they are, we will refer them to our outpatient, 822, our outpatient treatment program, where we have lots of CASACs and other groups available. But we also thought, okay, if that's not necessarily something that someone's interested in, we also want to, in the same building, be able to provide them an easy option to just maintain on buprenorphine if they're interested. And so coordinating that into our FQHCs or our primary care clinics, where we have integrated programming to include psychiatry providers, social workers, and primary care providers, all of whom can prescribe buprenorphine. I think some of the challenges that have been mentioned previously in terms of providers having waivers, and then, I think, just the process of starting out with a caseload, having that support. There's limitations in terms of how many patients or clients you can treat for a certain period of time, and that increases. They did just release different training requirements for NPs and PAs, so those barriers have been at least lifted a little bit, and we are actively getting and engaging our providers to obtain those waivers. Obviously, if folks are interested in long-term rehab from our ambulatory detox, we are referring them to those programs, but we're really looking to expand. This is an example of folks from our ambulatory detox into some of our programs. We obviously also receive referrals from the outside community to see our providers for maintenance as well. So we have ideas about expanding. We have providers that are interested. We're trying to coordinate, but we need funding for more peers. We need funding for a nurse coordinator for the BUP. That can be a barrier to the amount of time that it takes to sort of tackle all of the pharmacy restrictions and prior authorizations from insurance companies. So we have ideas about expanding, and I think are limited in some ways due to the funding, but we know there's lots of federal money that now has been put out there that we're hoping to obtain.
Thank you, Dr. Grolnick, and thank you to all the presenters. I want to thank you and your organizations for really thinking out of the box and for your commitment to save lives for our population, which has been ignored for decades. So now we will move on to the discussion part of the panel. And I would like to open this up to all the panelists here in the table. Combined, you all have had decades of experience in this work. How have you seen this crisis change over time? I can start with you.
Yeah. Like I said, I think that there have been opiate use for many decades, and we've seen a lot of people who've suffered from it. I think it's increased over time. I know that in large part, providers are part to blame for that. I think overprescriptions of opiates had kind of come about in the early 2000s. I think prior to that, providers didn't treat pain as much as they should, and then they kind of went the other to the spectrum, in part to blame, Purdue and Big Pharma kind of pushed opiates, OxyContin, and kind of proclaimed that it was safe and non-addicting. So I think in the early 2000s, you saw a lot of prescriptions for opiates increase greatly. I think they kind of doubled from 1998 to 2008 in terms of how many providers were prescribing opiates. And I think that, a lot of the stories that I hear now of people who've kind of gotten into an opiate or heroin addiction had started from prescription opiates that they had gotten for some physical ailment that they may not have needed prescription opiates for, and then end up having an addiction problem and requiring more medications and then getting cut off from it. And then usually what happens is that prescriptions are very expensive to buy on the street, and heroin's much cheaper. So people tend to go to heroin because it's a lot cheaper and more potent. And then that was kind of paralleled with the fact that fentanyl was kind of being put into heroin, and that made it, fentanyl is 100 times, if most people don't know, 100 times as potent as heroin. So it's very, very very potent. And so if you put even like a grain of that into heroin, it's much stronger than people are used to, and that's what triggers and has kind of spiked the overdoses that have occurred. So I feel like the problem is becoming a crisis because, you know, the amount of people using and kind of getting addicted to opiates has greatly increased, as well as the tainting of the heroin with fentanyl has made it much more deadly of a problem. So I feel like it's increasing, unfortunately.
For me, you know, it's interesting because I watch, you know, of course, as a police officer and then working in the prisons and jails and in the last 15 years at Acacia, the system began to get sort of feeling comfortable that they had this problem under control. So there was sort of a relaxation or less interest in really providing the kind of treatment that people needed. The programs began to, we changed to managed care, the time that individual could stay in treatment began to get reduced. Used to be able to stay in a treatment facility for 24 months. Then it came down to 12, now 9, and then now the managed care companies really will like you out as quickly as possible. So the system got comfortable. Then the explosion of the pain killers by the pharmaceuticals and the medical providers began to spread this disease from the inner cities out to the Midwest. It was there always, but not in the way that it exploded with the pharmaceuticals push on the pain medications. And then sort of this explosion sort of reverberated back into the cities over the last several years. And you can see that what seemed to be an issue that we were seeming to put our arms around exploded again back. It's like a wave. It went out, and then almost recently it came back into our communities. The one thing that has not changed is a lack of understanding of what it takes to treat this disease, and the pushback that you get both from sometimes elected officials, sometimes community people that don't really understand how complex this problem is. That has not changed. Whether it's then or now, you still have to, you know, sort of get into these communities and spend a lot of time and effort to educate the communities how important. And until somebody's lost to their own family or a neighbor down the street or it impacts them directly, they have a tendency to not be supported. They see it as a self-created problem and therefore not my problem until it hits your home. So that's one of the things that I've seen to change. This wave that went out and came back into ours, and it's back here full force in the pharmaceutical problem, which is, I think, we talked about funding. I also think it's one of the solutions for this, because if I were in a position that I would pass a bill, I would pass a bill that every pill has to have some kind of surtax on it to use dollars back to treat this problem, because I think it was created by them, it should be paid by them.
Luis, you want to chime in?
One of the points I'm always, even at this time, after so many years working as a counselor, is that, you know, clients and individuals that are struggling with opiate abuse, they're very smart, right? So they come on and tell me basically, you know, what's going on with what's going on in the streets with the heroin, what they're doing with the heroin now that, you know, they're using Percocets, okay? They're using Xanax and crunching them up and selling them as heroin. You're getting a lot of people that never, you see them walking down the street, you would never sell to, and these people actually there to buy heroin because of the pain medication that they're not getting anymore, you know, and also because of the pain medications that are too expensive for them. So now they're buying heroin, and it's becoming an explosion. And you see people literally. I'm from Washington Heights, and I see what goes on up there, and we have a huge park there. It's called High Bridge Park, and you basically literally see people sleeping in there, and I mean overdosing from the heroin that they think that they're taking, but it's actually pills, and with a little bit of slice of fentanyl, which is very potent. And literally, we have a lot of people that are dying, and sometimes they don't even know what they're taking. They think it's heroin, but it's not.
Dr. Grolnick?
The only thing I would add is that, within the homeless, unfortunately, this is not a new problem, and it hasn't necessarily increased. Particularly, I think the advantage or silver lining of some of the history of some of the prescribing and misprescribing is that nationwide there's more attention, because now it's sort of affecting all communities and all socioeconomic classes, and so now there's more attention, and that's okay. We can capitalize on that, and so. There is a little bit more awareness, and I think now all of a sudden, sort of in the midst of the crisis, some of the regulatory constraints and funding isn't necessarily catching up to the problem. So we are addressing it, but now there's sort of more and more needs that and infrastructure that needs to be in place, and the funding and regulatory restrictions haven't necessarily caught up. And the only other thing that I would add is now that fentanyl is being cut in a lot of the heroin, that perhaps someone who had been given Narcan previously or succeeded in reviving their friend or reversing their friend with one dose now, as many know, requires multiple doses to have the same reversal effect with the fentanyl because of the potency.
It's interesting. When I have these conversations in my communities, especially about the safe injection site and the funding that's now coming from the federal government, I hear the frustration from my community saying, we've been dealing with this for many, many, many years. Our communities, we've lost many family members and friends, and government has totally ignored us. Now that this opioid crisis is affecting affluent communities, now it's a national crisis. And my response to them is, you're right. It's unfortunate that is how the cards were dealt. But organizations such as yours, organizations that we have in our communities, should take advantage that now is a national crisis and funding has been allocated. But we need to be more vocal in saying we understand the issues. We've dealt with them for years in our communities. We should be spearheading this effort throughout the nation. What are your thoughts on that?
I just sort of preaching to the choir. I've been saying that now for the last 5 or 6 years as this epidemic seemed to go across state. Our organizations like Acacia have been in the lead doing exactly this to some of the affiliates like Promesa and Basis and other United Bronx Parents. We're prepared. We have the tools. We have the expertise. We have the history. We understand what works. We understand what doesn't work. And that's why when the Buffalo crisis came up, I went and spoke to Mayor Brown in Buffalo and said, Mayor, you know who I am. I was raised there. You know the organization I lead today. We're prepared to do this. And it was tough for him because he got a lot of pushback from some of his colleagues, but he said, let's go for it. And so you have to be aggressive. You have to jump in the mix and don't be afraid of the challenges, because other people are going to begin to catch up. All of a sudden, at Albany, there was one clinic barely being used. We opened up our clinic. Now there's 3 more opening up. We broke the barrier. We broke those barriers down, and people are coming through that. So we do have the expertise. We have the history. We have the talent, the people that work for it. We should absolutely be in the lead.
Dr. Grolnick, you spoke about staffing, and I know we spoke deep into funding. What are the barriers or challenges that you're seeing with staffing?
Staffing of providers, or?
Yeah, staffing of providers, or actually getting staffing to help address this epidemic.
So, as was mentioned, I think we are poised and ready. We are very well equipped to treat and all the myriad of challenges in the homeless population, and have been for decades. I think in terms of providers, there's a provider shortage nationwide, so New York City is not exempt from that in terms of just providers in general that are interested and committed to serving public sector in public sector clinics and agencies. So nationwide, across the board, psychiatrists have always sort of been a shortage, but now family medicine, internal medicine shortages for those folks dedicated to working within the community is also a challenge. I think that, so that's in terms of recruiting. We have many doctors and many doctors at this point that have waivers that are reluctant to prescribe buprenorphine, and this was something that was previously mentioned because of previous litigious instances. I think also developing systems and expanding our programs within the shelters. We have on-site healthcare in many of our shelters that are outside the FQHCs, and that presents different kinds of challenges in terms of providing the infrastructure to offer this level of care, MAT, in all of our programs. We're committed to doing it, absolutely. But I think we have more and more providers that are now interested in obtaining their waivers, and nurse practitioners as well, which will absolutely cast a wider net.
Dr. Littleton, you so your organization and my office, we work hand in hand. The living room is in the Hunts Point community, so I'm constantly having meetings with your president, CEO, and your deputy executive director, and also with the local community board, who Rafa Acevedo is here from community board too. I understand that the population that you're dealing with is a very difficult population. First, getting them off the streets and bringing them to the living room, you've achieved something, because a safe haven is for individuals who are chronically homeless. What are your challenges in dealing with this population, and how can the local community board and the local community and an elected official as myself help with some of these barriers that you may encounter?
I think that there are many barriers. I mean, I think the biggest one is with having resources for engagement. I think we have a 24/7 outreach team that reaches out to people who are still on the street. And when they find someone who, you have to approach someone multiple times before they are willing to try to engage with you and even think about coming in. And that takes a lot of time and manpower. So having the resources to be able to do that is really essential. I think getting the community aware of some of the concerns and problems, and so kind of being able to spread the word that these are our citizens, these are our family members, and to treat them with the same respect that you would anyone else. I think getting the community to work with us in that way would be extremely helpful. I know at the living room, there is a park that's literally like right across the street, but our clients are not allowed to really hang out in that park because of the community. They don't want to see them. And that's a big problem. They sit in the living room in the drop-in all day and have nowhere to walk or to just kind of hang out on a nice day. And so the community perception of people who are homeless, I think, needs to change. The issue about the prescribing patterns, we found there's certainly overall a shortage throughout the country of buprenorphine prescribers, but the Department of Health did a study on prescribing patterns in New York City, and it's definitely more buprenorphine prescribers in zip codes of more affluent communities. So there is kind of almost a biasness of prescribing patterns even within our city of providers who prescribe and why they prescribe. And I think a lot of that deals with the stigma that I talked about and people's concerns about who they're prescribing to, and if they have, other issues that they don't want to necessarily address. And so, I think getting providers the support to have some of those resources available to them, peers are a great resource, and so having the funding to be able to have more peers available, I think would really make people feel more equipped and able to help address all of the concerns of the patients that they're trying to treat.
Louis, what are some of the challenges that you feel that your clients are having, or some of the challenges that you may have in actually getting your clients to not miss their appointments and actually, come in and seek the help that they need.
Oh, wow, yeah, okay. So, there's a lot of issues. There are, right? Sometimes it's the smallest thing that we take for granted, like, the distance from walking because we get, our clientele not only come from the living room itself, they come from the outer area of the Bronx, and they got to come to us as an outpatient clinic. So a lot of the times it's just getting on the train to get to our center, just to come and see us for the medication and for the counseling part. And also, there's a lot of, how can I put it, the resources that we need, we need more resources than what we have right now. With us, it's only a two-person show. Our Suboxone clinic is very small at this time, and basically the clients that we are getting is literally through the word of mouth that we put out. I go out to the avenue and let them know that what we're doing. But basically, a lot of the times, it's the clients that are the struggles that they're having. It's just coming to the clinic, and they can't even make it sometimes because of the area they reside in. Sometimes just to get in the subway, I had a client the other day that couldn't come to see me because he got arrested. He couldn't come because he got caught in the subway
For jumping the turnstile?
Jumping the turnstile.
Well,
So it's those problems that we're facing a lot.
yeah. Well, we just yesterday the city council did that. We had our handshake with the mayor, where we approved an $89.2 billion budget.
Right.
And, as part of this budget, there's going to be $212 million set aside for fair fares.
Right, yeah.
For individuals or who have low incomes and have difficulties getting around throughout the city of New York for job interviews or appointments such as what you mentioned, where now they have access to this care, and a swipe will not be a barrier. So I'm excited about that. Raul, so Dr. Littleton spoke about community opposition, and I can understand some of that opposition, and I think one of the concerns is the overconcentration of shelters in certain communities. There are certain communities that have no shelters, but you have other communities such as Hunts Point who have cluster sites, have transitional housing, have safe havens. And so communities feel as if they are constantly, being, I don't want to, you're constantly concentrating these services in one community. So Raul, as an executive CEO, how challenging is it to convince a community that, hey, siting of a center or siting of a shelter or siting of a supportive housing, siting of a supportive housing, it's the right thing to do, especially oversaturated communities.
Obviously, you and I have dealt with that. I think that it takes a relationship with your community board. First of all, not when you're building the shelter, but before you're building the shelter, you want to go and visit your community board, have a relationship, have them tour some of your sites to show them the kind of work that you do. Obviously, it's also employment. Acacia Network employs approximately 4,000 people, about 70% of that in the Bronx. So that there are going to be great jobs. There are opportunities for expanding other resources into the community. Some of the things we did, for instance, I mentioned Buffalo, is that not only did we build like the methadone program, but we also worked on supportive housing and other housing needs, asking the community board what other services you may need that you can provide, that you're already providing, that you can share. It's developing a relationship with the folks in that community. Open communication. Open communication, not letting the community board know the day before you open the shelter that you're going to open the shelter. You have to have that relationship. I spend an enormous amount of time, working on those relationships with about every single elected official that's within the purview of the organization, so that when we do come with a project or an idea, they already know us. If you go in cold, the first time you go there, you're going to be in trouble. I remember the first time I met Maria Carmen Arroyo, at one of these meetings, she about threw me out of the office, right? But after that, the relationships over time began, and we did get a tremendous amount of help. Councilman, I just want to tell you that I have to step because I have to go accept an award that's St. Anne's Harm Reduction of $650,000 to share some of the work we're doing on this project. And I have to be about 3, but Lorraine Coleman, who's sitting right there, is going to come up and sit here and continue the discussion.
Thank you, Raul.
Thank you very much.
I have one more question for Dr. Grolnick, and then we're going to open up to the floor. Dr. Grolnick, we have taken many steps to deal with this epidemic, but how can we get in the forefront of this epidemic? What's the long view?
Right. So I think a lot of time and energy has been focused to putting on the Band-Aids, which are important. But we do have to think about other harm reduction approaches and really sort of preventative medicine and talking about it with folks before perhaps it happens. So, we are doing that. I think there are certain regulations that are changing in terms of prescribing patterns that were mentioned. In order to renew state medical licensing, it's a mandatory continuous medical education requirement in many states for those providers that need a little refresher in terms of appropriate opiate prescribing. And then it's continued harm reduction approaches to perhaps catch people in different phases of their recovery and really change that trajectory in a way that focus hasn't been. So MAT is one of the medication-assisted treatment, really has become a game changer. We can offer someone a safe alternative while they're receiving some of the other therapy and support services that are required to change and to address the whole person and all of the reasons that someone might go down a certain path and how we can change it. This is something that, as we've been addressing for decades, and I think really having a harm reduction approach more pervasive, changing our treatment systems that, rehabs are now approving folks that are on MAT versus, some of that dichotomy of abstinence versus harm reduction. So having some sort of consensus with evidence-based models that are working, we know that they work, and then it's just sort of actually having that to be more pervasive in all of our systems.
Thank you. So we'll now open up the questions to the audience. If you have any questions, just raise your hand, and there will be a mic that we brought to you.
Hi, everybody. Thanks for coming. I want to give a shout out to the council member. Thank you for all your hard work with the speaker to get fair fares in the budget. Big deal. And also, thank you on behalf of all our providers in the room for being such a great partner in the South Bronx. We're all really glad to work with you and look forward to continue working in the future.
Thank you. Allison, I know you mentioned, correct me if I'm wrong, there was like 75% of the doctors, there was a stigma against treating people with this crisis, correct? Something like that?
I think that was more, the stats that I had.
Right,
put
I'm
out.
sorry. And it was also mentioned that in the public sector, many of the private doctors don't want to treat people in the public sector. They want to cross over because of the funding and so forth. How do we work on providing an incentive program for them? I don't think we should have an incentive. They should just want to do it because they're doctors, but how do we work around that?
You can answer that.
There are some federal loan repayment programs that can help to incentivize providers to come and be committed for 3 years, for example. So there are federal programs that folks that are working within FQHCs are eligible for. I would say that the state of New York has offered a variety of incentive programs that have been very helpful as well. The Danny program this year that's being rolled out incentivizes providers to work in OASIS licensed programs. So that's very helpful, although we have providers prescribing BUP in all sort of licensed. So in Article 28 in the primary care clinics licensed by DOH, not necessarily OASIS. So, but we'll take it all. all. The incentive programs are a big draw for folks coming. That's one thing. I don't know if you...
Yeah, and I would also just add kind of mentorship and support. I do work with medical students from Einstein, like I mentioned, as well as residents from Montefiore, and I have them rotate with me regularly at the living room, and they sit and talk with me with the clients that I see and treat, and and I think through doing, you realize that these are just people like everybody else that we treat, and they're no different. They have different problems, but we all have our issues, and so I think from seeing and talking and hearing their stories, they understand that they are no different and should be treated like any other person. I think that's a big part of it, and also getting support for physicians. So like having kind of co-location of services kind of helps to refer when you're having difficult issues with a client and you need more intensive counseling and therapy. You have someone who you can kind of pull in to help you with that person, I think is also critical for physicians to feel more comfortable.
I would also add, if I could, if I just as a follow-up. So I think we have to work on addressing the stigma that was mentioned previously within healthcare providers and hospitals. Our clients are often admitted to the hospitals and treated by certain doctors that we might speak to on the phone. So it's addressing it from the training level, just what was mentioned. Residents actually rotate, medical students and residents rotating through. We also host a variety of students that come through. We have telepsychiatry that folks are interested in receiving experience with, and as a side effect of that rotation, we also introduce them to public psychiatry or public medicine in general. And so absolutely sort of demystifying what is it like to walk into a shelter, for example, sometimes really does the trick.
And just to add to that part of it, I think the interesting thing with residents and students is that a lot of when they see patients who have substance use problems, it's in a hospital. It's in an acute setting when they're acutely, kind of getting off of having a withdrawal or just having an overdose. And a lot of times their behavior may be very different in that setting than in an outpatient setting when they're feeling fairly normal, and especially if they're on medication where they're feeling stable. So, like their perception of a person is very different in those two settings. And so kind of getting the residents and students in an outpatient setting and seeing a patient kind of in their normal daily life helps.
We can tell we have two doctors in the room.
Yeah.
That's awesome. We're going to go on to the next question because there may be other people and we don't have much time.
Okay, just Louis. Louis, you mentioned about a person being arrested while they were trying to get treatment. How could NYPD be more helpful or be part of the efforts?
So how can NYPD be more helpful? Be more understanding and let them through. And they're going to treatment. I really think that they should have a little heart and just let them through. Because it could be saving somebody's life at that moment. Because sometimes when you don't take your medication, you could have other complications that could get very serious. So, yeah, just give them a break.
I think training of the NYPD, further training into, basic overview of mental health, substance use, again, to sort of have a more respectful approach. I've witnessed myself, I think, further training and actually responding to our calls in a way in certain precincts that they might not necessarily respond as quickly because they're often called, but there's a reason that they're called.
Yeah.
Yeah, and also building the relationship. They now have a lot of community officers that we work with collaboratively, whether it be in supportive housing or in the treatment programs, to really make sure that people are being diverted to the right area, that we're not criminalizing somebody who's in relapse and we're getting them into treatment. So we also send a lot of people to their community meetings to make sure that we have these relationships, and the more likely the neighborhood is to have the overdoses is where we send more staff and more clients to. We want to make sure we have a presence and we're working in a partnership regardless of the setting, that they know it's Acacia or whatever other agency. It's important that non-for-profits have a voice with the community.
I would Just also add that Project Renewal is partnering with the Department of Health and Mental Hygiene to open one of 2 diversion centers that will divert people with low-level crime and misdemeanors like jumping a turnstile, for example, into treatment. It's completely voluntary, and we will engage with them to offer detox and other services and MAT and others. So.
Thank you. Next question.
Hi, my name is Jerry. I'm with Samaritan Daytop Village. My question is, fentanyl is not a new medication. It's been around for years, but no one's ever really heard about it. It's never been in the newspaper. It's never been smuggled in from Mexico. Why now?
So the fentanyl that's in the heroin is not actually the fentanyl that physicians are prescribing. So it's not that the fentanyl is being prescribed by physicians. That actually is synthetic fentanyl that is made overseas usually and is shipped here illegally and then put into the heroin. And it kind of, will make the heroin more potent so that they can, have a larger supply of it. And it actually increases sales of the heroin because people will tend to buy it because they think it's more potent. So it's not really that the overprescription of opiates by physicians is really attributing it at all to the fentanyl issue. They're 2 separate ones. The fentanyl that we prescribe is usually in patches, and we prescribe very reservedly for end-stage cancer and very chronic pain. That's not what's really being prescribed by physicians. It's more of the oxycodones and the Percocets. So the fentanyl is being kind of illegally, synthetically brought into the country. Mm-hmm.
Any other questions from the audience? Yes.
Since we know that 80% of the people with an opioid addiction problem start by using prescription medications, and just my experience in working in the South Bronx, in hearing from our clients that there were all kinds of medical providers in the community that would prescribe medications for quote-unquote pain. I'm just wondering, what is being done to identify clinics and physicians that are purposely over-prescribing these medications to get people to come back and make money?
Yeah, so there's been a big crackdown with both the state and federal government to track physicians and their prescribing patterns. We now have to do it all electronically, and it's a kind of a dual system where we have 2 ways that we have to verify who we are when we send it, and it's being tracked. So the federal government knows exactly how many prescriptions for opiates I've written over the last year, and will graph it. And when your numbers are higher than normal, they investigate. We've had DEAs come to different practices to interview physicians who are prescribing inappropriately, and a lot of the kind of pill mills that you've heard about that happen in the South Bronx and elsewhere, where physicians who've kind of gone into it for the wrong reasons and literally do not talk to the patient but will give them a pill, have been shut down. So they are definitely making efforts to control the issue, the problem, and hold physicians responsible for their prescribing patterns.
There's also, in addition to that, a centralized system that you can reference, and actually we are obligated to reference the iStop, which is a centralized prescription log. So you can look up any client that has been prescribed any medication. If you're prescribing any controlled substance, you actually have to, you must reference this system and then document that you've done it within 24 hours of the prescription. And the idea is that you can see if someone sees 3 different doctors for 3 different reasons and someone's getting one treatment that might be contraindicated in combination with something else. It's a great tool that has really helped with the prescribing, and also, to engage with clients that might be doctor shopping to get something that they're interested in. And unfortunately now, as a result of that, there is more, I think, traffic on the streets because of that crackdown. But it's a good thing.
And they also, I think it was last week, there was a big arrest of a doctor in Queens, and because he was prescribing pain medications, really huge amount of pain medication to one individual, like 300 oxycodone for 1 month to one person, is, you know, the federal government is really cracking down on that. And this doctor, he said that the reason he was doing that, it was because he had some tax problems. So he basically had it was a pill mill that he had running in Queens, you know, in office, and they were coming from all over the tri-state area, and you know, and people knew that this doctor was going to give them a prescription and give them what they want, actually. But now he's not.
All right. We'll take one more question from the audience.
Does anyone on the panel have any experience, positive, negative, or otherwise, with another medication-assisted treatment I haven't heard discussed much, which is naltrexone or Vivitrol?
I have. I do prescribe Vivitrol, but in limited doses. So Vivitrol or naltrexone is Narcan, so it's an opiate blocker. It's used for overdose, but it can help a lot with addiction. And Vivitrol, basically how it works is it blocks any type of euphoria or high that you might get from an opiate, but you still have a craving to use it. The way that buprenorphine works, it's a kind of a partial agonist, and that means it kind of partially sits on the receptor, so you get some of the effects, but not all the effects. So a lot of people who use buprenorphine have no cravings, they don't have any desire to want to use, and if they do use, it usually doesn't have any effect. The problem with Vivitrol or naltrexone is that people still want to use, but they don't get the high. So they'll use higher and higher doses to try to get the high, but they never get it. So they end up typically having an overdose from it. So that's why I've only used it in very limited people who have, I feel like, enough supports to not kind of put themselves in that situation where they're going to have a lot of cravings and desires to use. So it can work, but it has to be for the right person and in the kind of the right setting, and it's not as effective, I think, as buprenorphine. So that's why it's not as widely prescribed.
There's a lot of pushback from the clients about using Vivitrol, I think for the reason that you mentioned, that they won't get that same effect. So we've actually tried to engage, and we do have some clients on Vivitrol for the appropriate client, but there's a lot of resistance and pushback from clients to make that selection.
And it's a little difficult because it's tempting. It sounds tempting because it's like, oh, I can take an injection. It's a once a month injection. I take an injection and then I don't have to think about it for a month. But that's not how addiction works, right? I mean, a lot of times you have to struggle with it every day. And so I think kind of what reasons people want to try to use Vivitrol usually are not the right reasons, and usually will result in them having a relapse. And that's also why it's not very effective.
All right, so I want to thank everyone for joining us today. Please give a big round of applause to the panelists. Thank you.